Thanks, everybody, for joining us. We're going to go ahead and get started just to be respectful of everybody's time today. And thanks for jumping on here. A couple things for you guys before we get started. Want to go ahead and do some housekeeping items, if you would. For any questions during the webinar, please use the Q&A feature. You can leave questions there, and we will definitely have time to answer them at the end. For ANA credit, the ANA has approved this for 1 CE credit. There will be an evaluation document that will need to be completed. It'll pop up in the browser at the close of the webinar. I also believe you'll get a follow-up email tomorrow with the link in it as well, so that you can fill that out. But in order to obtain the CE credit for the event, we need to have that document filled out, and I have a spot on that document to put your ANA number so that I can register with your digital profile as well. So it'll count toward your CE credit for the ANA. Your microphones will be muted during the presentation, so use the chat feature for any issues that you do experience, and we'll do our best to address them right then and there. If you use the chat as well for questions, that's fine. So you can either use the Q&A or chat, and we'll get to any and all of them that you guys have. So without further ado, I'm G.W. Hamilton. I'm the National Clinical Director from Synzyme. We are a quantitative train of 4 monitoring company that is supporting this event. And I would like to introduce our speaker today. This is Dr. Richard Flowers. He is the Assistant Professor, Academic Nursing, the Director of Clinical Education and Student Affairs of the Nurse Anesthesia Program at Wake Forest University School of Medicine. Dr. Flowers has nearly 30 years of clinical experience, graduated with his nursing degree. He probably will be mad because I'm bringing this up, from Memphis State University in 1993. His master's in nurse anesthesia in 1997 from Middle Tennessee School of Anesthesia, and his DNP from Baylor College of Medicine in 2016. Has presented topics to professional organizations and clinical practices across the globe. His presentation today, The Future is Here, Using Advanced Quantitative Neuromuscular Monitoring Technology to Improve Outcomes and Anesthesia. So welcome, Dr. Flowers. Thank you for agreeing to speak, and I'm going to turn the floor over to you.
All right. Well, thank you very much, George. Thank you to Synzyme for sponsoring this today. I am happy to be here. No, I'm not. It doesn't bother me at all for people to hear that I have a 30-year career. I'll say a large part of that, most of that actually has been in clinical practice. So I just want to start by saying to CRNAs out there, I'm one of you. I've been where you're at, done what you do, still do that clinically. Not quite as often anymore, but I still practice clinically and have the same problems and issues that you do. So I'm going to go ahead and share my screen here. All right, I just realized that I didn't change the title on this, but I really like this hashtag, residual paralysis matters. I hope by the end of this that you're going to agree with me and have a little more context of why that is the case. So objectives, my primary objective today is, well, let me give a disclaimer first. I will briefly talk about Sugammadex. I am occasionally paid by Merck to speak on that topic, so it's really the only disclaimer I have. So, but today, the opinions that I express here today are fully my own, well, at least my own and from the literature. Hopefully I'm going to give you some really good solid literature today to take back and stew on after this, but certainly don't always represent my employer, Wake Forest School of Medicine Nurse Anesthesia Program. So I'm here today representing myself and this problem that we have. Again, my primary objective beyond what you see on the screen here today is that you leave this with a different context maybe about the problem of residual paralysis and an open mind as to how you can change your practice. Now, I know I just said an extremely dirty word in public, and that is change. I know that CRNAs are not necessarily very happy with change. We're oftentimes resistant to change. So my biggest hope is that you leave with an open mind towards some things that you can do to improve your practice and outcomes. And my goal is to show that to you over the course of the next 45 minutes or so. I'm going to start with something a little counterintuitive, and that is to say that no question, the least evidence part of our practice in anesthesia that we do day in and day out is the management of neuromuscular blockade. And that's from start to finish. We are largely practicing purely anecdotal every day. So I know it's not good to start by calling you out, but I guess we're just going to go to church today. I've been accused of that before in this topic as being, I feel sometimes like an evangelist towards quantitative monitoring and neuromuscular blockade and prevention of residual paralysis. But, largely the way we're practicing in anesthesia in regards to this topic is we're choosing landline phones and dial-up internet when we have smartphones and gigabyte fiber readily available. It is residual paralysis, and residual paralysis in particular is a real problem that has real consequences. And despite what we think we see in our patients every day, and despite the outcomes that we think we're achieving, we're not coming close to what we could be doing. And there are problems whether or not we see them impact you immediately. And I'm going to expand on more about that as we talk. In fact, it's one area in anesthesia, the joke is that we get blamed for everything. And we've largely, for decades, escaped some blame for things that we are at least partially responsible for related to residual neuromuscular blockade at the end of cases. And I'll talk about why. So let's jump right into that. And I know at this point, I've probably got some people, because I've spoken on this quite a bit. And I actually put this slide in here because I had somebody raise their hand at the very beginning of a presentation, and they're like, "That's just your opinion." And I'm like, "Yeah, but my opinion's truth. So let's keep moving." So I threw that in there. I'm going to jump in. I want to start with monitoring, just so we're on the same page with some terminology. When I'm talking about residual paralysis, what does that even mean? Well, honestly, what is the opposite of residual paralysis? It's full recovery. Okay, either when we get to the end of the case and we've administered neuromuscular blocking agents, either they're fully recovered or they're not, right? So residual paralysis means that there is something left. Well, how do we define that? Well, it's been defined actually for quite some time. And the definition of what I would describe as clinically relevant recovery from neuromuscular blockade. And that's really what we're concerned about, right? We know that sometimes things in the literature and research get talked about, oh, this is statistically significant. But yeah, but is it clinically relevant? Does it really matter if I have $99.90 or $100, right? What's the difference there? Is that relevant to my checking account? So clinically relevant recovery from neuromuscular blockade is solidly defined in the literature and every anesthesia text that you read today as a train of 4 ratio of greater than 0.9. Now, if you are not using quantitative monitoring and you went to school 30 years ago like I did, you may be actually thinking, what in the heck is a train of 4 ratio and what does it even mean? The technical answer is it is a ratio obtained by dividing the amplitude or the height or the strength of the fourth twitch by that of the first. So we know when we do a train of 4 that we have 4 twitches if we are at that level of recovery. And with fade, the first twitch is always higher than the fourth twitch, right? Unless you are 100% recovered and you have 0 fade, you're always, the amplitude or the height or the strength of the first twitch is going to be more than the fourth twitch. So if we're dividing the basic elementary math here, right? If we're dividing a small number by a bigger number, we're going to get a number less than 1. So anything less than 1, or as the literature defines it, clinically relevant, anything less than 0.9, we'll go into more detail about that in just a bit, is some degree of fade and some degree of residual blockade. But if you look at that and you think, well, 90% or 0.9, anything below that is not acceptable or is not clinically relevant recovery, that's actually quite a small margin of error, right? 10%. So there's not that big of room when it comes to the definition as to what's good and what's bad. Okay. So there's two methods that we monitor blockade, right? Qualitative or subjective, or the same, qualitative and subjective, or quantitative, otherwise known as objective. Now, the only way to obtain a train-to-4 ratio is through quantitative or objective methods. Now, I know that most of you probably on this webinar today, because most of the people around the country have practiced in different places, talked to many people about this subject, actually don't have quantitative monitoring available. And that's really why we're here today. So an overwhelming majority of us open the top drawer of our anesthesia machines and we find something that looks like this. Typically the battery's hanging out. It's got pink tape, maybe not white tape around it, holding the battery in. You have no clue whether it's working or not. You hope that you have a nurse anesthesia resident with you that you can ask them to stick that 9-volt to their tongue and see if it's still working, right? Or hey, test this on a train of 4 on your wrist and see if it's working. But this is what we have. I realized the first time I used these pictures, because these are actually my devices, that I really dated myself, because this was some pharma swag that they used to hand out back in the day when that was still allowed to new anesthesia students. So I'm dating myself a little bit, but sadly, even though these devices are almost 30 years old, it's the same thing that you probably have in your OR today. The technology when it comes to this device has not changed at all. And if it has, it really hasn't changed to give us any more useful information. We're using the same things. Now I have a question for you out there, and you can nod your heads out there in cyberspace, but are these devices monitors? When I ask that question, and I can see faces and can hear answers, I get varied answers. People are kind of like, I don't know, or yeah. Well, the answer is no, it's not a monitor at all, because it's not providing you with any information. A monitor gives you objective data. This is purely just a device that elicits an electrical stimulus. So the technical term for this is a peripheral nerve stimulator, right? And that's what we know this as, is a stimulator. So it elicits or gives an electrical stimulus, which then hopefully elicits a response in the patient, which you are assessing either by visual assessment or touch, right? So you're the monitor. This is not the monitor. You're the one interpreting the data and actually measuring the data either through visual or tactile assessment. You're making the assessment and you are the monitor. So this is just a basic electrical device and not a monitor at all. Thus the term qualitative or subjective, because your impression, kind of like the previous slide, that's just your opinion. When it comes down to it, you're doing your best job to make an assessment, but it's your opinion of how many twitches you see or how many twitches you feel. So that would be qualitative or subjective data, okay? Now, how good are we at this? We're terrible. We're really bad. We have known since the 1980s that our visual and tactile ability to detect fade, which is really what we're looking for, right? When we're talking about recovery of neuromuscular blockade, is limited at a train of 4 ratio of about 0.4 or 40%. So when the recovery exceeds that, when recovery is beyond that, our eye can't tell a difference between 0.4 and 1.0. Now, if you go back to what I just said, what clinically relevant recovery is, I said it was 0.9. There's a huge gap between those two, right? I mean, that is a really big difference between what are the limits of our visual and tactile assessment and where we need to be. We're cross country. It's a big difference. We're not even close. So we're really flying by the seat of our pants using peripheral nerve stimulators and making any sort of assessment as far as whether or not a patient has achieved clinically relevant recovery. So again, we've known this since the 80s. Now, not only can we not see fade, I love this study, it's astounding. We were all ICU nurses for CRNAs here. So we can't bash on nurses too bad because we are nurses. But not only can we not see it or feel it, we can't even count them. So this was a study done with ICU nurses who use peripheral nerve stimulators a lot. In 80 assessments, they only estimated correctly about half the time. And a quarter of the time, or actually about 17% of the time, we're off by 2 twitches. Makes a big difference, right? And honestly, when this is duplicated in anesthesia providers, we're not that much different. It's really easy to miss subtle changes when we're using tactile and visual assessments. While we're here, I'm going to jump right on this one. And this is another common area where we absolutely, without question, practice and use anecdotes over evidence. I can't see your faces, so you can answer honestly, but how many of you primarily use the facial nerve for stimulation in lieu of the ulnar? And does it matter? Does it make a difference? Well, the answer is yes, absolutely, it does make a difference. Now, I fully understand that many of the cases we do now, we have arms tucked, right? And that's an issue. Robotic cases, oftentimes you can't even get to the feet. You know, we think, well, I could go to the foot, but you can't even get there. So sometimes you are left when using a peripheral nerve stimulator with nothing but the face, right? But it absolutely does make a difference. In study after study, it has been shown to make a difference. And just so you know, the standard, when we talk about clinically relevant recovery and every study, what is the standard? What's the standard location? Well, the standard reference point used in all research since early days of research in this area is the ulnar nerve or the adductor pollicis muscle, okay? Why is facial monitoring not good? So facial nerve monitoring overestimates the degree of train of 4 by about 2 twitches a majority of the time. So what do I mean by that? If you have 2 twitches at the face at the end of a case, you're thinking, I'm good, right? I'm at a point where reversal is possible. I'm at a solid place. When in reality, if you were to measure at the ulnar nerve, a majority of the time, you would actually have 0 twitches at the standard reference point. How many of you would jump right into a reversal in a patient with 0 twitches, especially if you were limited to the use of neostigmine? We're in a completely different boat here with significant clinical outcome differences, right? So I'm jumping ahead a bit right now, but it's a problem when you are choosing and dosing reversal agents based on an assessment made at the facial nerve. So that's an issue. So what can be different about that? And what do we do different? And I know we're at a point where you're going, well, all I have is a peripheral nerve stimulator. What am I supposed to do? And what do we do on a regular basis to assess? We don't just use peripheral nerve stimulators to assess recovery, right? We do other things. And I know that this is where you want your patients to be at the end of the case, right? We use clinical signs. So what clinical signs do we commonly use, and are they reliable? How do they help us in getting to this goal where our patients are doing this and jumping over to the stretcher on their own? Well, what we know about clinical signs and their reliability. Well, let's go back. Let's jump back and do a little history lesson here. We've had some form of quantitative monitoring since the 70s, really. 70s, early 80s. And the OG, the original form that was used in the lab, was a device based on mechanicomyography technology, which is cumbersome and really difficult to use in the clinical setting. But using that, it was determined in the 70s that patients who could open their eyes, stick their tongue out, had a strong grip strength, could take a big deep breath, that forced vital capacity, and could lift their heads off the bed for 5 seconds, correlated with a train of 4 ratio of about 0.7. All the things that I just listed are the things that you're probably doing every day when you get to the end of a case. You're asking your patients, you know, if they're waking up, hold your head up. You're sometimes checking their grip strength, but primarily you're concerned about the diaphragm and you're concerned about their tidal volume and their respiratory effort. And I know we all look at those things at the end of cases, but do they matter? Right? Well, if you look at this number, 0.7, is that 0.9? No, it's not. So does that get us to the prize? Does that get us to the goal of clinically relevant recovery? It doesn't. Okay. So the number 0.7 was really not arbitrary, but it was really just based on the fact that patients who could do these things seemed to be at about 0.7. And these are the common tests that we use to determine readiness for extubation. So, okay, that's obviously going to be the goal then. And for several decades, that's where we lived. If you looked at a textbook in the 80s, it would have said a train of 4 ratio of 0.7 is clinically relevant recovery. But at the time, very few people in the country were using devices, quantitative monitoring devices that could even measure that, right? They just weren't readily available. But it was a textbook number that maybe you needed to know for the NCE exam to pass your boards, right? It was something we learned and forgot and moved on. In the 90s to around 2000s, we started realizing that, hey, even when we achieve these things, people still have problems. There's still problems. Why are people having problems? And we started looking at and really learned at that point that, you know what, that diaphragm that we're so concerned about, the patient breathing that we base everything on, are they ready to extubate? Maybe that's really not what we need to be looking at. And we actually realized, and when I look at this now, it's like, gosh, that's astounding to think that that's 20 plus years ago when we really discovered the importance of pharyngeal muscles, which are these neck muscles here, right? What is so important about pharyngeal muscles? Well, pharyngeal muscles control a lot of body functions that are really important to recovery and maintaining a patent airway postoperatively and preventing silent aspiration. So when we look at pharyngeal muscles, they are really important when it comes to postoperative recovery and how a patient's going to do, and in the prevention of something I want to call critical respiratory events. Critical respiratory events, things like postoperative pneumonia related to aspiration, reintubation, not maintaining a patent airway and having to intervene. Those would all be critical respiratory events. And it was determined at the time to have full return of pharyngeal muscle function requires more than 0.7, thus the standard of 0.9. So this move from 0.7 to 0.9 really came about because we discovered that the pharyngeal muscle function does not return until you're at 0.9. Now, we have a pesky little problem in the world, and especially where I live, called obstructive sleep apnea. And in those patients who are already compromised, their ability is most likely to return, is most likely even higher. We actually need to be closer to full recovery in those patients who already have compromise, pre-existing compromise. So again, clinical signs really are not supported as a valid assessment tool to determine whether or not you have met the goal of a 0.9 train of 4 ratio or met clinically relevant recovery from neuromuscular blockade. So really now, the focus has changed from what we see at the time of assessment to things that we might not be able to see. You know, your patient, I think it's hard sometimes, this discussion is hard because if you're not using quantitative monitoring, you don't have a context of what really the patient looks like between a 0.4 and a 0.9. And quite honestly, when we're thinking about it in that perspective of what does a weak patient look like, the first thing that comes to mind in most anesthesia providers is, oh, it's the floppy fish, the person that is struggling. But that's not true at all when we get to these higher levels of residual paralysis. When we think about the difference between 0.7 and 0.9 or 0.6 and 0.9, these may be patients that you drop off in PACU and you think, I just did the perfect case. I just landed this plane perfectly without a bump on descent, and you didn't even feel the wheels hit the runway. And I got out of PACU, they looked perfect, they weren't complaining. I gave report and I am in and out in 38 seconds, and this is a beautiful day. When in reality, that patient has not achieved clinically relevant recovery and may have a train of 4 ratio of something far less than 0.9 that could lead to outcome differences that you're not seeing at the time. If someone has residual paralysis to the degree that they're going to be floppy, they're having a hard time breathing, they're really low on that ratio scale. And I'm going to show you here what I mean by that. So in this slide that I adapted from a study, it really does a good job of showing the number of patients that can achieve certain clinical outcomes, assessment outcomes, compared to a train of 4 ratio. So when we look at the thing that the number one predictor that we're all looking for, the number one assessment for recovery at the end of the case, and we talk about their ability to breathe and maintain an adequate tidal volume, almost 100% of patients, right here, almost 100% of patients can do that with a train of 4 ratio of 0.2. We're down in an area now, and actually it's probably even lower than that. We're down in an area where we barely even have 4 twitches. And you should certainly be seeing some fade, right? And you all know this because you have patients and they don't even have 4 twitches sometimes, and your surgeons are going, hey, this patient's breathing, right? And if you're monitoring at the ulnar nerve, that may very well be the case. You may have 0 twitches and have a surgeon say that, hey, I'm getting some respiratory movement. And then you measure at the face and you're like, oh, I hate using the ulnar nerve. I really have 2 twitches, but no, you really have 0. And this proves that all the way down here at 0, where you may not have twitches yet, these patients can have some respiratory effort. Because if you track this off the scale over here, you're going to come way off to the left of where your twitches are at, right? But the key point I want to make is almost 100% of patients can breathe with a significant amount of paralysis in place. Okay, so there's our number one clinical sign. Head lift, is it any better? Not much, right? Over 75% of patients can sustain a head lift at a train of 4 ratio of 0.4, which again, that's about where we lose the ability to see that fade. Hand grip, tongue protrusion. This red line I drew in here myself is approximately 0.7. I didn't measure it out, but it's pretty close. So as you can see, most of these things, those patients can do at 0.7, which is what they determined in the 70s, right? Now, look at between 0.7 and this green line is approximately 0.9. Airway obstruction. Look how steep this curve is. So this is where we're getting to say that those pharyngeal muscles, the muscles that are keeping our ability to maintain a patent airway and protect our airway, to get up to where we have any significant percentage of patients that can achieve those things, we're way up here on this 0.9 mark. That curve is really steep. And actually all the way over here, closer to 1.0 until we're close to this 100% line. So as you can see, almost everything on this page is to the left of the 0.9 mark, meaning that those clinical signs that we rely on day in and day out are not valid assessments of where we need to be, even though they are still an integral component of most of our daily practices. Now, I want to say this here, that I'm not picking on you just to be picking on you. As CRNAs, as anesthesia providers, we do a really good job of taking what we're given and doing the best we can with it. And I fully realize, because I also practice clinically, most of you don't have the tools you need when it comes to making the assessments that you should be making. And you're using what you have to do the best job you can. So I do want to make that statement. Although a recent study showed that almost 10% of US anesthesia providers don't monitor at all and rely solely on clinical signs. And that number is much higher in parts of Europe and especially Asia. So that's always astounding to me that people are practicing every day using neuromuscular blocking agents and using no stimulator, no monitor at all. So, okay, I know you're here right now. So you're like, what the heck am I supposed to do? And I know you have some questions, because I'm going to jump here next. I think many people have the idea that, but we have Sugammadex and it's just the answer. Why do we need monitoring? Because this was the holy grail of fixing all the problems, right? So what's up with that? And we all know that in studies, this big Cochrane review, that when we compare head to head, that yes, absolutely, no question, Sugammadex is faster. It provides clinically relevant recovery in over 90% of patients, or approximately 90% of patients, in a really short period of time. We focused on the time a lot, in this study. It's all really was looking at time, that 95% of these patients achieve recovery, a train to full ratio of 0.9, and when we're at the 2 milligram per kilo dose in less than 2 minutes, and it took 13 minutes for neostigmine. This one really is not even appropriate, because we wouldn't use neostigmine in those instances where we had less than 2 twitches typically anyway. But is it the answer, or is it not the answer? What we've determined when you look back at these numbers, let me go back to this. There's study after study that has shown that the median times for reversal in using to obtain a train to full ratio of 0.9 when we're using neostigmine, if you have 2 twitches, it's about 23 minutes. 3 twitches, it's about 16 minutes. And if you have 4 twitches, it's about 10 minutes. How many people actually wait 22 minutes to extubate a patient after delivering reversal agents? Nobody. We never do that. It's not a clinically relevant amount of time. So when we're talking about when is the appropriate time to choose which agent, what's really coming out in the literature is really the only time now that neostigmine should be used, especially if you're without having quantitative monitoring available, is in a patient who already has 4 twitches. So, for those of you who don't have it, may the 4th twitch be with you. But again, isn't Sugammadex the ultimate anesthesia mulligan? Didn't this just fix the problem? And if everybody used it, again, why do we need monitoring? Well, the fact is that even when Sugammadex is used exclusively, the incidence of residual in almost every study is at least still 10%. it's still a significant number of people, right? When you think about if 10% of the population, that 10% of our cases are still going to PACU with residual paralysis. And I know in healthcare economics that you guys are limited quite often in what you are able to use. So there's a push to use cheaper drugs, right? There's a push to do things differently. But why is it that we're still seeing 10%? Is it not the holy grail answer to solve all the problems? Well, one of the reasons I mentioned earlier is monitoring location, right? If you're basing reversals on facial nerve location, you're either underdosing or choosing the wrong agent for reversal a significant amount of time, right? If you have 0 twitches, that's a different dose of sugammadex than if you have 2 twitches, right? If you have 2 twitches, you may choose to use neostigmine, or 4, where you might choose sugammadex otherwise. The reason I bring that up is there's another good reason, and it's lack of data. And that's a perfect segue into really why we're here today. And that's quantitative monitors. So how does that change? How does quantitative monitoring change the pictures? Well, first, let's spend just a minute and let's talk about the different types of monitors, because I think this is really important and how this technology has progressed. Some of you are probably familiar. I'll start on the right with this device here, which is called kinemyography. Okay, this device is really old technology. I actually used this 20 plus years ago. Okay, it's been around for a really long time. And if you have GE or Datex Omeda anesthesia machines, they typically try to get you to purchase those machines with a package, monitoring package, and I think it's called NMT on those. And it comes with, you can see a couple different things here. This kinemyography device, which is a piezoelectric strip that goes between the thumb and the forefinger. And honestly, if you've used these, you've probably been just as frustrated as I have with their use. And that's very heavily reported in the literature, that not only the frustration aspect of these, but that the fact that they're not really reliable and accurate in comparison to the standard that I mentioned earlier, which was mechanical myography. They're really not a good estimate of what actual recovery is. And the frustration is related to the fact that this requires the perfect application of your electrodes to achieve the perfect twitch where the thumb bends this strip, because that's how you get monitoring. And if you've used these, you know the frustration of you put your electrodes on and you get great twitches in your pinky and your ring finger, but it doesn't bend the strip, and you look up and it says you have 0 twitches, but you're visually counting 4 twitches. So that's one of the frustrations. And you certainly can't use this if your arms are tucked, right? Other types of devices, this, while I'm here, is also a picture. What are these other EKG electrodes for here? They also have an EMG device, which I'm going to talk about in just a minute, that is a 5-lead device that you've probably seen. If you're familiar with this, you've probably seen, at least in a drawer, that 5-lead attachment, but you may or may not have used it. Acceleromyography, what is that? So probably in the 70s and 80s, if you used a device other than this, you may have used a device called the TOF watch or the Trainer 4 watch that was an acceleromyography device, which is based on Newton's second law, force equals mass times acceleration. I'm not going to go into a physics lesson here, but basically it's measuring the movement of the thumb, okay, or acceleration. It's similar to what you have in your iPhones, right? Accelerometers that measures things with drop and different things. So, but these monitors are quantitative monitors. Every one that I'm on here is an objective quantitative monitor. And the Trainer 4 watch is no longer available. There are new devices on the market. This picture here is a device called StemPod that is an accelerometer device. And the newer devices are what's known as 3D technology. So it does record in this picture. Let's say you have the sensor on the thumb. No matter which direction the thumb moves, it's going to record the acceleration of that and give you a train of 4 ratio. So the 3D, you may hear them referred to, are the newer technology devices. There's a couple of those on the market, the StemPod, and then the TOF is another one that's available that are 3D technology. I think some Philips monitors have some built-in devices. There's a couple of others out there that are available. So how do they compare to the standard of mechanicomyography? Certainly better than kinemyography, although there is a difference, and that difference is about 0.1 or 10%. So when we say that we need to achieve a train of 4 ratio of 0.9, we really need to achieve a 1.0 if we're using this type of technology to be confident that we've achieved that 1.9, because they do overestimate just a little bit. And then now we get to what I would say is the newest really technology and the most advanced technology, and that would be electromyography or an EMG device, which Tetragraph by Senzyme that's sponsoring this is one of those examples. One of the key differences between these that I want to point out is EMG monitoring actually doesn't require you to see or doesn't require movement of a digit, okay, because it measures the electrical response. It's measuring the action potentials, measuring the response to the stimulus. These all still use a train of 4 stimulus, but they measure those in different ways to quantitatively or objective obtain that train of 4 ratio. As you can see, this device uses a strip, and I refer to it a biz-like strip, right, that goes on. So a key element in EMG monitoring and a benefit is that these devices can be used with the arms tucked. You can put this on and tuck the arms. You don't need to see the movement, and it's going to give you a response. There's another technology out there called compressimyography that uses like a blood pressure cuff, but recent literature I've seen have also shown that there's some accuracy issues in those, or reliability, when compared to the standard of mechanicomyography. I think the key point here is the technology has advanced quite a bit. There is technology available that, as you can see in these devices, handheld, easy to use, easy to read, and it's there. We've gotten to a point where the technology is available. We can do this, and it's very easy to use and interpret. Much actually, when you start using it, because of it is actually giving you information, it's much easier to use than a nerve stimulator that you're having to make an assessment on. But I do want to point out a very clear point. Quantitative objective devices are the only devices that can measure train of 4 ratio, and the only devices that can objectively assess whether or not you have achieved clinically relevant recovery from neuromuscular blockade. Nothing else does. Anything else is like driving a car with a broken gas gauge and speedometer. You're either going to find yourself on the side of the road one way or the other. Either you're getting pulled over by a cop or you ran out of gas eventually, because you're using subjective methods. I'm going to move beyond that. So, okay, you're saying now, that's great, but does it make any difference? What's the benefit of doing this? Because I've been practicing the way I've been practicing, and my patients do fine, right? My patients seem to do just fine. I'm still not buying this. So what is the big difference with quantitative monitoring? This picture shows that we actually have better monitoring. We get more information. More and more cases that we're doing, when I mentioned robotic cases, are really requiring us to do anesthetics at a much deeper level of blockade than what we've ever done in the past. There's actually some outcome differences too, like post-op pain. There's some data showing improvement in post-operative pain when we have deeper levels of muscle relaxation. So it's indicated for an increasing number of cases, and it's really hard to assess that level, that deep level of blockade using a peripheral nerve stimulator. Whereas EMG and even accelerometry technology allows us to do that. And as you can see, this picture shows that this is a post-tetanic count. Typically, these monitors will measure when there's not a train of four present. It will move to a post-tetanic measurement where it's assessing 20 post-tetanic twitches. Well, this patient is really deep because they have 1 out of 20 post-tetanic twitches, right? That's a really deep level of blockade. I work with a plastic surgeon who asked for muscle relaxation to infinity, and this is pretty darn near close, right? So we're pretty deep here. But it allows for more objective redosing as well. So on the flip side, we may be able to sometimes use less muscle relaxant because instead of just guessing, oh, I'm going to give 20 milligrams of rocuronium every 30 minutes, it really gives us a better assessment of where we're at, where we're going, and allows us to tailor dosing throughout a case better and to possibly even use less in cases where we don't need that deep level. Certainly can also sometimes allow us to tailor reversal dosing. You know, I know anecdotally, there's a lot of people trying to use a lower dose of Sugamidex, for instance, to save money. Without quantitative monitoring, that's a really risky game because there's a good chance you're not going to achieve the goal that you want to. But using quantitative monitoring, there's certainly nothing wrong with using less. And if you don't get to where you need to be, give more. But I would caution that that should only be done in the setting of objective monitoring. So it could be one side benefit of using objective monitoring. But I know you're still thinking, is fancier and faster really better? So the last thing I want to touch on here is just some outcome things. So what do we know? We absolutely know that there are outcome differences in patients who receive neuromuscular blocking agents versus those who don't. We have known this since the beginning, since we took curare from the jungles and started using it in patients. There was a really huge study by some Harvard physicians in the 1950s that showed a drastic difference in outcomes between patients who receive neuromuscular blocking agents and those who don't. This has improved, but not entirely. There is still a difference in 2022, despite everything we do. We know that absolutely in study after study in academic medical centers, community hospitals, every place around the country, that a significant number of people arrive to PACU extubated with residual paralysis with a train of four ratio less than 0.9%. In an average of studies that I've seen, it's somewhere around 60 to 65% of patients are arriving to PACU with residual. We absolutely know for a fact that patients with residual paralysis, those patients who are arriving with a train of four ratio of less than 0.9, have a higher incidence of critical respiratory events. There are outcome differences. We know that very small degrees of paralysis may not be clinically evident, but are absolutely clinically relevant. And we also know that pharyngeal muscle function is the most important thing in maintaining a patent airway, preventing aspiration. And again, some studies are pointing that a train of four ratio closer to 100% or 1.0 is required for full return of function, which makes sense. It's full recovery, right? So this is a fascinating study or article, and this was published last year. So what about, again, what are the outcome differences? Well, let's look at monitoring alone. This is fascinating. Temple University looked at their population. They determined that they had a 60% incidence of residual paralysis. They do 7,500 cases a year that require neuromuscular blocking agents. So about 4,500 of those, 60%, are at risk for complications, right? They determined that overall, when they look back at cases, they have about a 4.2% incidence of postoperative pneumonia or reintubation. So when you do that math, just under 200 patients a year have both residual paralysis and an event. their average cost for an event was $36,000. You add that up annually, $7 million a year cost to the healthcare system for those patients with residual paralysis that had events. It's a lot of money. That's not for one institution, that's a lot of money. So they estimated that if they bought 30 objective quantitative monitors at an estimated cost of $2,000 and amortize that over 5 years, they're spending about $12,000 a year and then about $150,000 a year on disposables. So what would it take to break even and get to, so I left out one piece. The general population has a critical respiratory event rate of about 2%, no matter what you do. So they determined if to reduce that, if they could get rid of residual paralysis and reduce it by 60%, how much would we save? A complete reduction would have been $7 million savings. But in trying to be realistic, they said it would only require them preventing this in 5 patients out of that 60% to break even, with a potential cost savings of $5 million a year if they just got to the level of the general population of 2%. That's astounding to me. Now, this is a projection, okay? So it's not, they're projecting this difference, but the potential cost savings there is huge. And we all know that money matters. So how about Sugamadex? Well, certainly we know that using that does reduce critical respiratory events. But again, I think the point I want to make here is it's not fully, there's still 10% of patients even when we're doing this. And I think it's largely because most of these studies were not done using objective monitoring, okay? Now, how about when we do both? This is a study just published last month and published in Anesthesiology, where they had a protocol in place for reversal agents and they used objective monitoring. So was there an outcome difference when we tried to do both? 20,000 medical charts review, and this is what they found. Post-implementation of a protocol for reversal combined with objective monitoring resulted in shorter PACU lengths of stays, pulmonary complication differences, 43% difference, and a reduced hospital length of stay. So now we're talking about better outcomes for patients, along with a significant reduced cost savings. So why hasn't this been made a standard? I get asked this question. If this is the case, then why aren't our respective agencies telling us, hey, you need to use this? Well, number one, I think it's because for decades we didn't have the technology. It's not a problem anymore. We have the technology. Honestly, it's coming. The standard's coming. It's coming to an OR. It's coming to your OR, like it or not. Just last year, the UK Association of Anesthetists, I think I said that right, said that anytime neuromuscular blocking drugs are used, quantitative monitoring should be used. Just last month or the month before, the Anesthesia Patient Safety Foundation came out with a much stronger statement also in that regard. So just a couple, I'm going to wrap this up, but some food for thought here. Will outcome-based reimbursement change your practice? That's coming. The days, it's already here, but we're moving towards, in the United States, a system where outcomes aren't good, you're not paid. And we're now linked with postoperative pneumonia and significant outcomes that are related to residual paralysis. Is the potential for those complications enough to drive change and to change your practice? And is it even ethical to not use evidence-based best practices just for cost savings? And I think finally, the question I have for you is, what are you going to do with this? My objective was really for you to have an open mind. You are the end users, as George would say here. You are the people who drive this change because you're the person in the room doing the case, picking up a monitor, and you have a voice. You can take this information to your leaders and say, hey, why do we continue to buy devices that are not giving us information when the data shows that this could improve both outcomes and the bottom line of your department? You have a voice. I would urge you to go to your leaders and say, hey, have we looked at this? Can we do a trial? Can we get a company in here to bring some monitors in and show us the difference? There are differences, even though you may not be seeing them. There are differences. Residual paralysis matters. And you have the power, you have the ability to change that. The technology is readily available. The companies, Senzyme, the other companies are more than happy to show you how they work, to bring in, to do trials and to get things in your hands. And once you start using them, you're going to be like, oh my gosh, this is so easy. Why haven't I been doing this, since they have been available? So thank you for your time. Sorry, I pushed it right to the limit, but if you have any questions, I do have references here. Everything that I told you, even though it may have sounded like my opinion, was absolutely related to a study or something published in the literature. This is my email, rflowers@wakehealth.edu. I'm happy to help you, answer any questions, give you my reference list, anything I can do to move this along and reduce residual paralysis and get us to a point where the norm is objective quantitative monitoring, and we are making significant outcome differences in our patients. So.
Thanks so much. This is awesome. You answered a lot of the questions that were actually on, particularly at the end there. You covered about why the limited adoption, and I think you touched on that, which is great. And the Sugamidex question came up that you already addressed as well. Well, we have Sugamidex, why not? One of the things I'll ask that did come up a little bit, somebody had wrote in the Q&A, was about what about added to workflow. I think it's largely a struggle for folks. Just the pressure at the beginning of a case to get things moving and done.
I think
about the added workflow.
Yeah, I can touch on that because I've used, I used despite the frustration, I used the older devices that did have a significant workflow. And I think one of the benefits of the newer technology is, although it's preferred, you actually don't have to have a baseline. You certainly get a little better data if you do a baseline, but that was one of the frustrations before, was trying to get it all attached right. And the beauty of having a disposable along with a monitor is that you can place that disposable preoperatively. I can put the disposable on in the holding room, roll my patient back, plug the monitor up, push drugs enough that they don't care, get a baseline. And I don't really feel that with the new technology that's available now, what you can get on the market, that the workflow is any different at all. Actually, it improves it because you're getting it on at a time when you can start your monitor and actually determine when your patient's ready to intubate, so that you're not throwing a tube in and they're coughing. We don't talk about it very much about using it in that aspect because it's something is not a common practice in everywhere to monitor at the beginning of the case, but because it is so easy to place that early in the case, you do have it readily available to you at that point. So I would say that it's actually an improvement in workflow in my perspective, because it's on, it's there. And then if you're going to tuck arms, you've already got it on, your cable's plugged up, you're good to go.
Awesome. Well, again, thank you everybody for joining us. And when I close this out, you guys should get a link to complete that evaluation so that you can get your CE credit. Just make sure you include your ANA number so that I can file with the ANA, and that should be done sometime next week. I should have it done, and it should post to your CE profile. So Dr. Flowers, we greatly again appreciate it. Wonderful talk.
Enjoy.
Yeah, and thanks, and really enjoyed it. So thanks again, guys, and look forward to seeing you on our next webinar. Thanks everybody, and have a wonderful rest of your day. Thanks, Dr. Flowers.
Are you gonna shut this down, I guess?
Yeah,
okay.
And I'll shoot you an email, or we if you want to, we can chat, whatever you want to do.
Yeah, it sounds great. Thank you.
Okay. Yep, you bet.